If you're joining us for the first time, we welcome you. And if you're coming back, welcome back. I'm Clayton Powers, a full-time physical therapist at University of Utah and also the education liaison for Bateman Horne Center. I'm joined by Sarah Day, Project Echo lead at University of Utah. And today's session is being recorded, but all participant details or sensitive information will be removed before it's shared on the website or social media. So today we're privileged to have Dr. Melanie Hoppers from Bateman Horne Center back to present to us the second part of long COVID in children. So Dr. Hoppers, I'll turn the time over to you to share your slides. And
So I come from the Bateman Horne Center. We are a 501c3 nonprofit organization. We focus on clinical care, research, and education regarding infection-associated chronic conditions that include myalgic encephalomyelitis and long COVID and their comorbidities. Permission has been obtained prior to sharing any patient information. Additionally, just for an extra layer of protection, I've compiled several patients into each case so as to protect their identity. However, each representation is fairly representative of patients that I see. I don't want you to feel like I've exaggerated any symptoms because sometimes when you hear the symptoms, it would almost sound like one was. But this is what real patients present, how they present. I have no disclosures to discuss. Neither I or the Bateman Horne Center receive any financial benefit from inclusion of any products, services, or companies. In part one, I talked about long COVID statistics. We defined ME/CFS and discussed post-exertional malaise and orthostatic intolerance. Pediatric long COVID has many facets that could be discussed, but due to time, I had to pick a topic, and I thought that mast cell activation syndrome would be fairly impactful as many of my patients have symptoms consistent with this diagnosis. Acute COVID-19 illness causes a cytokine storm with rapid proliferation of hyperactive T cells, macrophages, and natural killer cells. There's this overproduction of cytokines and chemical mediators that are released, and this activates our mast cells during this illness and in other infections as well. SARS-CoV-2, as you know, they directly activate mast cells through ACE2 receptors, and mast cells have these in abundance. It is thought that long COVID and its persistent inflammatory state will activate mast cell genes, and this causes an abnormal mast cell activation. Additionally, viral infections can trigger autoantibody formation that interacts with mast cell immunoglobulin receptors, causing ongoing activation even after the acute infection resolves. So this was a study. This was conducted by Dr. Leonard Weinstock and others, and you have to listen carefully because it's sort of confusing when I explain it. But it's what they did is they recruited people who were healthy controls, people who had long COVID, and people with mast cell activation syndrome. And they had them fill out questionnaires. The questionnaires, there was a validated mast cell questionnaire, one regarding fatigue symptoms, quality of life symptoms. And the healthy controls filled out the questionnaire. The people with long COVID filled out the questionnaire, and they were to do one set of questionnaires were done with recalling to mind what kind of symptoms they had prior to developing long COVID. Then they did the questionnaires again, documenting the symptoms they had now that they had long COVID. Then the patients with mast cell activation syndrome or to fill out the questionnaires as they recall their symptoms before they were treated. So we're comparing the symptoms between the groups, right? The three groups. And what they found was that patients with long COVID, when they filled out the questionnaires, recalling their symptoms or lack thereof before their illness, they were very comparable to the general healthy controls. When they redid the questionnaires based on their symptoms of long COVID and compared those with the patients with mast cell activation syndrome, they found that the symptom profiles were virtually identical between these two groups of patients. So, and this is interesting. I know whenever I look at, whenever I'm talking about long COVID and I talk about what the symptoms are, and then I think about dysautonomia and I talk about what the symptoms are, and then I talk about mast cell, here's the symptoms. I feel like I'm saying the same thing over and over again. Symptoms are quite similar. This is just a spider plot illustrating what was found in that study. Again, the green and purple are comparing the healthy controls and pre-illness long COVID patients. And then over on the right with the peach and red are after their illness has begun and compared with mast cell activation syndrome patients. So mast cells are a type of white blood cell. They are located in our connective tissues and at the interfaces between the external environment and the body's mucosal membranes. Also the skin, the GI tract, the GU tract, and respiratory tract. Mast cells act as sentinels that patrol at the body's portal of entry. I tell my pediatric patients they're like soldiers, constantly looking for any sort of invader. Interestingly, mast cells are co-located with blood vessels, nerves, and connective tissue. This allows them to be strategically positioned to modulate sympathetic activity and vascular tone through mediators. And if you think about our talk about orthostatic intolerance and how there's venous blood pooling, and so there's stretch of those blood vessels, that stretch can activate the stretch receptors on mast cells, which are inconveniently located near those blood vessels. Inconveniently, I say sarcastically, but and so they can kind of feed back on each other because then those mediators that are released can do things like cause vascular permeability. So the roles typically for mast cells, as we know, allergy and anaphylaxis, but they also play a role in wound healing, angiogenesis, immunity, pathogen defense, and that vascular permeability. So there are two major categories of disordered mast cell activation. Disordered activation is when mast cells are overproduced or when they're too easily activated, leading to the release of excess mediators. So when I think about my training, mast cell disorders consisted of mastocytosis. This presents excess number of mast cells. It's a rare clonal disorder that occurs when mast cells are overproduced, growing unchecked. I heard about it one day in a lecture. I never saw a child who had mastocytosis, but mastocytosis is rare in children, but the most common form is cutaneous mastocytosis. About 55% present by the age of 2, another 10 before the age of 15, and then the other 35% are at age 15. They have that classic kind of salmon colored rash, brown lesions. And this is something different from what we're talking about. So what I'm talking about is these mast cells get activated due to something like an infection like COVID-19, and now they're hyper responsive. They're twitchy. I tell my patients it's like the soldiers that have been patrolling for days upon end, and they're tired and they're spooked easily, and so they get exposed to something that normally wouldn't cause a problem, but now they're overreactive and they're going to react to that foreign invader, whether it's a smell or it's a new food or something like that. So diagnosing mast cell activation syndrome is complicated enough in adults, and I'll kind of go through this quickly, but one of the requirements is that you have episodic symptoms of mast cell mediator release in 2 or more organ systems. It can be the skin, the GI tract, respiratory tract, GU tract, nervous system, respiratory system, any area, but 2 or more. You also must have improvement or clinical response to treatment with medications to target the mast cell mediators. Also, and this is the kind of the difficult to attain criteria, elevation of a validated marker of mast cell activation. And sounds easy enough, but easier said than done. So you have to either get serum tryptase, chromogranin A, plasma heparin or histamine. There's urinary mediators, PGD2, BPG, leukotriene E4. So the problem with these, though, is that these mediators are very labile. They're heat sensitive and they degrade quite quickly. And these can't be run at your local lab. I found the hard way they can't even be drawn at, at many of the local labs. You have to have a chilled tube or a chilled urine cup. They have to be immediately placed on ice. They have to be kept frozen. They have to be transported to wherever they're going, perhaps across the country, on ice and stay frozen the entire time. Well, you can see that that may be difficult. And some more rural settings may really have a hard time getting this done. I believe that you have to centrifuge it before you send it, and it has to be done in a refrigerated centrifuge. So if you don't have a place that's drawing the blood where you can centrifuge in a refrigerated centrifuge, then you have a problem. So that's kind of difficult. So I do try to get mediators. I do the labs. If they're negative, I don't rule out anything, but if they're positive, that gives me some evidence toward a diagnosis. So in kids, there's no established guidelines for diagnosis in children. This is where it gets a little tricky, right? So in adults, it's hard enough. In kids, we don't even have guidelines. Now, the Mastocytosis Society, they suggest using the adult criteria and mention that several allergy immunology societies do this. What I do when I see patients that I think have activation of their mast cells, I don't diagnose them with mast cell activation syndrome per se. I use it's a code D89.40, and it's mast cell activation unspecified. So basically, I'm saying their mast cells are activated and twitchy, but they don't necessarily meet all of those criteria. Now, I looked really hard to find something more about the criteria, who's using what, which of these are okay to, check in kids, which are helpful, and didn't find a lot of good information, but I did find two good papers. There was a retrospective chart review of 104 children. They had suspected mast cell. They checked urinary and plasma serum markers, and they found that PGD2 was the most frequently elevated marker. And then there was another case series of children that had presented to an allergy gastroenterology clinic with symptoms that were suggestive of mast cell. 87% had an elevated mediator. The most common was the 2,3-BPG in urine. When I check, I oftentimes find methylhistamine in the urine, histamine. Rarely tryptase will be elevated, prostaglandin D2. So it's just kind of a gamut. And again, I'm not hanging my hat on anything, just trying to gather more evidence. So when mast cells are presented with either a trigger or an allergen, they become activated and they release chemicals or mediators in the form of degranulation. This can be IgE mediated, but also direct activation of receptors. For example, temperature changes can lead to degranulation. There are over 1,000 mediators that have been identified, so you can imagine this goes with an array of symptoms. Histamines, leukotrienes, prostaglandins, heparin, tryptase are just a few of the mediators that we are aware of. Once activated, though, these mast cells can act locally, but they also can send distress signals through the nervous system and endocrine system, and this can initiate a cascade response in distal areas of the body. Think about people. I have patients who eat a certain food and they experience brain fog. So that's just an example of how that can occur or how that can look. So triggers are really important. Triggers are kind of whenever I listen to a lecture, I'm like, okay, triggers, yeah, I get it. You have triggers and you need to stop them. But really and truly, when you're caring for a patient, this is super important. Again, in kids, it's super important. I don't want my kids on a bunch of medicines. If I can do anything to treat them without giving them a medicine, that's what I'm going to try to do. That's my first goal. So really thinking about triggers are important. And I talk about this with patients and their families. Here are the things that can trigger you. Be on the lookout. If you know what to look for, maybe you never thought about the fact that the sunlight could be causing the trigger, or is the trigger that's causing your mast cell symptoms. So if they know about the triggers, that's helpful. There's a lot of education involved with this illness. So heat, cold, or just temperature changes can trigger mast cells. Stress can activate mast cells. Corticotropin releasing hormone receptors are present on mast cells. So stress can literally cause mast cell release. Mechanical irritation, so pressure, friction, vibration can trigger mast cells. I have patients that when they ride in a car, they have mast cell release. And I've realized it's really hard to stop the vibrations in a car. You can put a lot of cushioning in, but you still can feel a little bit of vibration. Pay attention the next time you're driving. Exercise can trigger mast cells. Food and beverages are particularly common. There are some that are more common than others. Aged or fermented foods, processed meats, things containing preservatives, shellfish, nuts, particularly tree nuts. Also, something you may not have thought about is leftovers. So food has bacteria that converts histidine into histamine as it sits there, even when in the refrigerator. So I asked my patients, I saw this the other day when I was reading, and it said, prepare just enough food. I guess they don't, I don't know, living at my house, I can never predict exactly how much food to cook. There's always way too much or not enough. So, if you can do that, good for you. But if not, freeze it immediately. This slows down the process. It doesn't stop it completely, but it does help to some degree. Medications can be a trigger. Opioids directly bind to the receptors of mast cells and can activate them. For some, it's the active ingredient, say like penicillin in an antibiotic, but also preservative dyes or fillers. Um, this can accompany those active ingredients and can be the problem. I have learned that if they have a lot of medications listed, I start thinking about mast cell activation. In adults, you can see a huge list. They've lived longer and have been exposed to more things. Kids, 2, 3 allergies. I'm like, I'm going to pay attention here. So that's a clue. Also, of course, infections, as we mentioned, COVID-19, smells, chemicals, tobacco smoke can activate mast cells. Sunlight can trigger mast cell activation. It causes a production of these chemicals in the skin that can provoke the mast cells. Hormonal changes. People who have menstrual cycles may notice a change at various points in their menstrual cycle, so that can be a trigger as well. So just kind of making the family aware, making the patient aware, depending on their age, as to what they can understand. Because remember, again, this can affect toddlers, infants. So, teens especially, they're more in control of what they're eating and what they're exposed to. So they need to be educated as to what can cause the issues. Once you find them, you want to eliminate them. Symptoms, again, like I said, just think about what we said. What are the symptoms in long COVID? Same thing here. Anaphylaxis, of course, and allergies. We think of that all the time with mast cells, but also easy bruising and bleeding. Remember, heparin is one of the mediators. Rashes, lots and lots of rashes. Itching, flushing. They can have GI distress with nausea, reflux, bloating, constipation, diarrhea. I see a lot of GI symptoms in kids. There's also wheezing, chest pain, tachycardia. Again, that orthostatic intolerance is very frequent in children. They may have vertigo, flushing, edema, headaches, and cognitive impairment or neurological symptoms that they may have. They also can have GU symptoms. You have somebody that comes in and they have symptoms of a UTI, but their urine is always sterile. Something to think about is mast cell activation. So what can we do? Again, first thing, educate, talk about triggers, have them do a diary. And as I say, identify and avoid triggers. I also realize this is a huge, it's a huge task. I never know how to say this, but my child has ME/CFS and mast cell activation syndrome. And sometimes what did we do? What happened? I don't know where this came from. I can't figure it out. Adhesives, we know if any adhesive comes in the house, we're going to have a mast cell reaction. Yeah, but there's also sometimes it's a mystery. I don't know why the itching started. Maybe it's stress. Maybe it's the orthostatic intolerance has triggered it. But really trying to find those triggers can be helpful. Diet, look at what they're eating. And a lot of people will advocate a low histamine diet. And that's great if you can do it and you can still get good nutrition and all of that. But it is hard. It's hard to stick with. And sometimes you think you're doing a low histamine diet and, you go out to eat and you find out there's things in the foods you didn't realize. So reducing processed foods, reducing fast foods, trying to kind of cook anti-inflammatory, cook with organic foods, healthy fruits, vegetables, emphasize those sorts of things in your diet. So our pharmacological interventions, this is sort of a relief that we have things that we can give children that have been used, that are used. So it's okay. It's okay if you give them an H1 blocker or an H2 blocker. That's where I start. Again, don't forget that H2 blocker. That can be very helpful as well. I have patients that famotidine is the thing that really helped them the most. With the H1 blockers, you have sedating and non-sedating. I typically start with the non-sedating. I occasionally will add in something like hydroxyzine at bedtime. If a child have a particular patient I'm thinking of that has a lot of nausea, so we use cyproheptadine for him. But additionally, if you have a patient who has a lot of brain fog and a lot of sedation, a little pearl I learned from Dr. Larry Afrin was that Giving them a sedating antihistamine at a really low dose may help that daytime somnolence and cognitive impairment that they may have because it crosses the blood-brain barrier. And if their symptoms are being triggered by a mast cell in the brain, then you need to get something that will penetrate that blood-brain barrier. And I found that has helped with some of my patients. So that's a neat little trick that he taught me. Mast cell stabilizers can be used. Cromolyn sodium. There's Gastrocrom that you can prescribe, but then there's also cromolyn sodium can be compounded. Ketotifen, it is a weak H1 blocker, but also a mast cell stabilizer, as well as supplements such as luteolin, rutin, and quercetin. Now, the mast cell stabilizers help prevent the release of these mediators, but it doesn't help if you take it PRN. It's not to be used acutely. It's not going to do you any good. You need to have the patients taking it and let them know it needs to be taken every day for it to be effective. And then leukotriene blockade. So this is something that in kids, I feel a little squeamish about, right? That a lot of side effects and black box warnings. And so it's not something I take lightly if I have a patient who has a lot of problems with, asthma, wheezing, and if they are particularly ill, particularly reactive, and we've tried other things, then I might consider it with very careful, extensive counseling and, a plan if depression begins, stop it immediately, call me, those sorts of things. So I put that on here, but I just want to emphasize that I take care. I don't just flippantly put a kid on that. So I'm going to turn my attention to the patient cases. This is where I really wanted to talk today. And I'm just going to be quite honest with you. This is the good, the bad, the ugly. I'm going to tell you the mistakes I've made. I'm going to tell you the things I've learned along the way. Please don't judge me, but if it's fine if you do, it's okay. I judge myself quite harshly. But so I'm going to start with this patient. And again, like I said, this is a compilation of several patients, but she's fairly representative of someone who's mildly affected. Well, she has mild illness at this point that she's treated. I should say that. So she's 15 years old. She was healthy, had normal development, normal birth history, regular childhood illnesses with viral infections and such, but nothing that was significant. No surgeries or anything like that. In 2022, she developed an acute COVID-19 infection. So 2022, you think that's pre-Omicron variant, which is more likely to cause long COVID. She had a mild-ish illness. She had respiratory symptoms, a couple of days of fever, headaches, fine. There was never any concern that she needed to go to the hospital, no respiratory distress. Her acute symptoms resolved about a week or so into the illness. And she felt like she was fine. She had started to go back to school, doing all the things she does. About 2 to 3 weeks later, she started to develop GI distress. Started with just some bloating, and occasional constipation. Occasionally, she'd have diarrhea and it just progressively worsened. It was about a year before I saw her. So she was sick for about a year. So over that year, she had progressively worsened until she was bloating on most days. And she felt like every day she either had constipation or diarrhea. She said this was an extremely intrusive problem and was really affecting her quality of life. Additionally, she had a lot of rashes, itching, flushing. She had noticed that at school when they were cleaning or other kids had, perfumes or lotions and things on, that was irritating to her. Matter of fact, and here's one of my mistakes. On our first visit, I walked in, I laughed, not because it's funny, but because of my ignorance. But on our first visit, I walked in and she's flushed and she's itching. I feel like I can see the rash breaking out in front of me. Said, are you okay? And so, well, when I was in the waiting room, I could smell some cleaner. And so, here's what's happening. So I got to see firsthand her mast cells in action. So we don't do that anymore. We don't spray Lysol either. We used to go in we had people who go out there and spray Lysol, and my patients just don't tolerate that at all. So we have a new policy at the clinic here in Tennessee. She also had symptoms of orthostatic intolerance. She had tachycardia, palpitations. She had a little bit of chest pain. She would feel lightheaded. She said at school, a lot of times she would sit there, and it's usually about mid-morning. She said about mid-morning, I would just, all of a sudden, I would feel flushed. I would feel myself getting hot, and I would feel a lot of anxiety, and like my heart's just pounding out of my chest. And she's sitting there with her feet on the floor. Now she's about 2.5 hours into school, and I think her problem at that point was orthostatic intolerance. She also just kind of had that look of wired but tired. I can't explain it exactly, but she's sitting there talking to me and she just looks like she's vibrating in the chair. And it's funny with kids, or especially with kids, it feels like, especially teens, a lot of them present like that. They just look like they're on fire. And that's kind of how she felt to me. Like everything was wired up, everything was just, the nerves were standing on end. We had her come back, did a passive stand test, like we talked about in our last lecture. She had an increase in her heart rate of 52 beats per minute. This was around minute 8. She had no drop in blood pressure. She did have a narrowing of her pulse pressure from 40 to 22. She had symptoms. She felt dizzy. She felt anxious. Her hands and her feet were cold. She had poor capillary refill. So she met criteria for POTS. The other thing that's important in her history is she was experiencing post-exertional malaise. Now, she said she always felt she was feeling tired a lot of the time. And she would do her thing. She had started to modify a few things. She wasn't doing quite as much as she used to. She'd come home sometimes and just have to kind of lie down. But she noticed two events that she thought was that she shared with me. And one was at the end of the semester, she had had a series of exams. And after the exams, she felt terrible. She came home and just went to the couch, said I was either in the couch or the bed for about 4 or 5 days. And I felt terrible. I felt like I had the flu. And she said the same thing happened after homecoming week. She's a busy girl, lots of extracurricular activities, and same thing happens. But she had at least 2 episodes of post-exertional malaise that were pretty significant, in addition to other times where I think she had post-exertional malaise as well, just they weren't as dramatic. So what did we do? So the first thing, oops, sorry, I'm going to go back. So the first thing I did was address post-exertional malaise. I feel like this is really important for patients to understand what they're experiencing. She's lived 15 years and never had this happen. None of her friends do this that she knows of. Her family members don't do this. So this is something she is experiencing with no form of reference, right? So the first thing I want to do is define it, tell her what it is, and tell her what's happening. She expressed a lot of relief. Just knowing and understanding may be a bit of a stretch, but just hearing what it was, hearing the cause and effect made a big difference for her. She's a really sharp young person. And she talked about it with me. And she said, I've thought about it and I do. She was in drama club and in chess club. And she said, I'm going to quit drama club, stick with chess club. And kind of that was one thing she did to reduce her activities. And just a few other things that she made changes and was able to, and she knew we put accommodations and modifications in place as well. This was for school, right? And for home. So she got out of doing her laundry chores. So that was one thing she liked me for that. But the school, at first we did accommodations. Can she take a test in another area? Can she have extended time for the test and all that? But really, what I needed to do, I learned, was modifications. Can she take a shorter test? Can she demonstrate her understanding, and let's be done with it? Let's don't make her sit there for an hour, because an hour sitting in that chair was starting to cause her symptoms to occur. So it's really important to do that. I found a lot of times with accommodations, you're making it worse because the child has to go home and do these things at home with no help from their teachers. So that's not always the right way to handle that. Again, learning on my part. So once we sort of had that, we had some stability there. She had understanding. We were working on it. It's always a work in progress with post-exertional malaise. I asked her, what is the thing? To me, it was her GI symptoms, but I wanted to confirm with her. She said, yes, indeed, the GI symptoms are the most troubling and intrusive of my symptoms. I would really like to get these better. And so I started her on Zyrtec. And a couple weeks later added Infamotidine. It's very important with these patients or people who live with ME/CFS that you go slow, especially with kids. I go really slow. I use low doses, one thing at a time. That's very helpful because if you have side effects, obviously you know what it is. But if you have improvement, you know what's helping. Also, it's interesting sometimes what symptoms are improved. It's sometimes not what I'm expecting. So, you may give Zyrtec and you may actually find improvement of the orthostatic intolerance. Dr. Bateman talked about that on a talk a long time ago. It was a patient she had who, if she took her antihistamines, she could stay upright longer. So sometimes it's a surprise. So you can learn from it. So, go back after you've done something and listen to what the patient has to say. It can really teach you some things. So good thing for her, and it was really exciting. She had a lot of improvement with this. She said about 80% improvement of her GI symptoms simply with Zyrtec and famotidine. She also had reduced frequency of her rashes and flushing and sensitivities. The important thing is with of that, now she noticed, and now she was really bothered by her heart rate and her hyperdynamic, that pounding chest pain or pounding heart rate that she would feel. So we addressed that. We started with 5 milligrams of propranolol. Again, I start low. I start her, I says 3 times a day, but really ultimately through the day. I start once a day. It's sort of a test. It's meant to help you. It's meant to see if some side effect's going to pop up. So I'll start really low, then kind of gradually increase and got her up to 5 milligrams TID, ultimately to 10 TID. And this really helped her OI symptoms. She was really happy with the improvement. Her ups and downs were, a much lower curve with ups and downs, more steady. There was blips along the way, but we would work through them. And she really, again, this sharp, super, super great person, and was really happy with her progress. So started, didn't see her as often. When you feel better, you don't see patients as often. And she came in about 6 months after I'd last seen her. This has been a year or two ago, and she was really in a bad place. She said, I feel terrible. My GI symptoms are coming back. Rashes are coming back. I'm itching. She just looked like she felt bad. Um, and so we started going through what has changed. It was really simple. She had started a job. She was a teenager wanting to live her life, wanting to do what other teenagers do. And so she had taken a job at a fast food restaurant. And she said, the thing that really bothers me the most is when I have to clean at the end of the night. And she's smelling these chemicals, exposed to these chemicals, and it just set everything off. And so I said, you're on one, two, three, 3 medications at this point. I really don't want to add a medication. How about you quit your job? And I don't even know what the word is. I hate to say quit your job because that sounds like I don't know, negative connotation with the word quit. Please remove yourself from the trigger. That's what I want you to do. Um, and she didn't like it, but she did. She took a little while to think about it, but her symptoms continued, and so she did. And she got back to where we had gotten before. And, just an example of how removing the triggers um, is really one of the most important things. If there's no mast cell mediator release, you don't need to take medications for it. So that's my first patient case. And then now patient case number 2. Now the first patient I just talked about, you know, is she was fairly straightforward. Of course, we had blips and glitches along the way, but again, fairly straightforward. You get a lot of positive feedback. Things are going well. That's not always how it is with this illness. This illness is very difficult. There's very low, you look at symptom scores, low quality of life. It's very debilitating and very terrible for a lot of people. So I want to share a patient who's a bit sicker for this case. So this was early on for me. Now I am lucky to be at the Bateman Horn Center, and we have resources and we're allowed time to see our patients. We are able to spend a lot of time with our patients. I also know that there are way more patients than the Bateman Horn Center can possibly see, and primary care is seeing patients with long COVID, and they need to treat. We can't try to find, good luck finding someone to see pediatric patients as a specialist. You're not going to find a lot of long COVID clinics, a lot of MECFS clinics that see pediatric patients. So it's on primary care providers to do this. And it's really important. So anyway, I'm what I'm my point is I'm going to give you some tools that are quick and easy. And you don't have to do 12 questionnaires that take you 3 hours to go through to see the patient. But what I was using at this time in my clinic here in Tennessee, before I was at BHC, was this good day, bad day questionnaire that I had gotten from the Bateman Horne Center. And it's a beautiful, beautiful questionnaire. You can, in 3 minutes, get an idea of how sick this patient is. So before I saw this patient, I had this questionnaire. The mom had filled it out, and it's semi-accurate. She said it was really hard. She wasn't exactly, she got a little confused about some things, but we asked about good days and bad days. How many a month do you have? What can you do on a good day and bad day? What can't you do on a good day and bad day? And how many hours of upright activity do you spend in a 24-hour period? Now, this means feet on the floor. So if you're sitting with feet on the floor, if you're standing or walking, that is included in your hours of upright activity. So you can see this child was experiencing 25 bad days a month and 5 good days a month. On a good day, she could go to school and stay the whole day. This happened once or twice a week, maybe. If she did, she typically missed the next day and maybe even the day after that. She called some in between days, and she said on the in between days, she goes for a couple of hours and calls me to come pick her up. On either day, good day or in between day, when she gets home from school, she goes to bed. She sleeps sometimes until the next morning. Sometimes she'll get up and eat something, maybe do a little bit of homework, but that's all she was doing. On bad days, she did nothing. She slept and she slept and she slept. This child could sleep more than it is just a lot. She could sleep 2 to 3 days in a row, get up, go to the bathroom, maybe eat something, and that was all she did. Just very sick, very fatigued, and wasn't doing any extracurricular activities, wasn't hanging out with friends, wasn't, playing or anything like that. So this was her existence. Then the other really nice questionnaire is this orthostatic intolerance questionnaire. Again, I first just look at it. Where are the X's? And you can see on her slide here, these are, 6, 5, 10, I think that's 2. So most of them are on the right side. That gives me a clue, right? And if you look at specifically what they're saying, she has a lot of dizziness, lightheadedness, problems with vision, weakness, and fatigue was 10. So you can see kind of what the problems are. And again, next this talks about, walking and standing, short time, long time. Again, she's a 4, an 8, a 5, and an 8. So again, that just tells me things aren't going well in this direction either. So she was 13 years old. She had SARS-CoV-2 infection in November 2020. Fever, myalgias, headaches, sore throat. She was a little sicker with her illness. She had kind of a bit flu-like, but never any concerns for breathing, never any concerns for hypoxemia. They had a pulse ox and checked it and reported that when she was ill, there was never any concern for anything like that, just over-the-counter measures. Around day 7, the fever, the myalgias, all that had stopped, but still it wasn't okay. She never felt good after that infection. I don't know if mom said essentially she's never felt good since then. She's always tired. I'll find her on the couch. I'll find her asleep. She just doesn't do anything. She's a different child. In the meantime, while they were grappling with this, trying to figure out what to do, they went to primary care, urgent care frequently. She had frequent episodes of sore throats. Mom, I think I'm sick. Check my temperature. It'd be 99, 100. Never really going into that, 101, 102 phase. She would go to the urgent care. They would do the typical cocktail of, let's check COVID, flu, and strep. Most of the time negative, occasionally strep, but for the most part, everything was negative. But she would have a red throat and swollen lymph glands. So I saw her about a year or two later after all of this. By this time, again, you saw her good day, bad day questionnaire. She was struggling to try to get to school, struggling to continue to do what everyone thinks you're supposed to do when you're a kid. You're supposed to go to school. Everyone was trying to get her there, and it was a losing battle. She had impaired function. She couldn't attend school normally. She couldn't do her chores. The playing with friends had ceased. Orthostatic intolerance. Again, she had the visual disturbance with standing. Mom reported cognitive impairment, said she had trouble doing homework. She was more quiet, less animated, withdrawn. The patient told me a few years later, when she could reflect back, about this time, and she said, I didn't know I had cognitive impairment. I had asked her these questions. She said she didn't think that she had a problem, but she told me, I just thought I couldn't understand things. I just thought the work was too hard. I didn't know that it had anything to do with what was going on with me. I just thought there was something wrong and I just wasn't very smart, which really made me sad to hear that. And now I try to really remember to talk about this with kids, and just talk to them about that so they're aware that it has to do with their illness. She had a lot of sleep issues, as I said, hypersomnia, but then sometimes she would have insomnia and couldn't sleep when she needed to at night. She had occasional nightmares. She also had sleep or sound and light sensitivity, a lot of nausea, a lot of nausea, some constipation and abdominal pain. She had occasional headaches and rashes, not constantly, but she had episodes of that. And then flushing was another frequent symptom. So physical exam, we oftentimes say there's not much to find, but there is. I mean, they're subtle, but they're there. Again, one of my mistakes, we had bright overhead lights, and this is her pupils in the bright overhead light. Now we have lamps and reduced lighting in our rooms. She's pale, dark circles under her eyes. She appeared tired. She looks like a kid that's coming in with the flu. Her head's leaned over. She can't even keep her head up. She's so tired. She had a Beighton score of 6. Pulmonary was and lower extremity were a little bit around ankles. This is the rash. She didn't have this rash when I saw her. This was a few years later. She actually had a stellate ganglion block, and this is the rash that she developed after the procedure. And she had frequent rashes like this. If she got an IV, sometimes this would occur. If she put a Band-Aid on, this kind of rash would occur. So we had her come back and do the passive stand test. And this was quite revealing. Recall that we have them lay down for 10 minutes in a quiet room, check their vital signs. At the second check, she had a heart rate of 68. So this was after 10 minutes supine. When she stood at minute 1, she was 118. At minute 9, she was 160. So she had an increase in heart rate of 92 beats per minute. I wasn't expecting anything quite so dramatic. Her blood pressure hung in there for a little bit. Her diastolic rose, pulse pressure narrowed. She was trying really hard to keep up with her cardiovascular output, but around minute 7, 8, everything kind of went. It was gone. Her blood pressure dropped to 94/54. She felt terrible. She was dizzy pretty immediately. Extremities were cool. They started out cool, got colder. Started out red with her hands and feet and got a little purplish toward the end. She appeared kind of distant at the end. And she's still mad at me about this test. So be prepared for that. So what did I diagnose her with? So first, long COVID. She has a post-viral illness. She meets criteria for ME/CFS. She has post-exertional malaise, cognitive impairment, orthostatic intolerance, sleep disturbances, functional produced in extreme fatigue that is not relieved by rest. She also has dysautonomia, orthostatic intolerance, symptoms of inappropriate mast cell activation, again, sleep disorders and cognitive impairment, GI issues, headaches, and hypermobility. And that is a lot of diagnosis for a kid of 13. I do try to put them all in because I think that maybe for statistical purposes, that's helpful. I don't know if that has anything to do with what we get research funding on, but, I just feel like I want all the diagnoses in. So so we have data for this. So the first problem for her that had to be immediately addressed was post-exertional malaise. Remember the definition. There's a worsening of the patient's symptoms. And I can tell you, I have learned from patients post-exertional malaise. I want a label that I can copy and paste into my chart. Patient is in post-exertional malaise. Everything is bad. Then patient is not in post-exertional malaise. Everything is better. It's just simply, that's just it in a nutshell. If they're in post-exertional malaise, their symptoms are going to be out of control. There's going to be lack of stability. They don't tolerate things. You try new medications and it does not go well. They don't respond well. They'll develop side effects. And so,
I don't.
oh, sweet.
No.
You really want to get them out of post-exertional malaise. It's also very miserable. It's a condition of suffering. Also, the more time you spend in post-exertional malaise and the more severe your post-exertional malaise, this tends to correlate with clinical worsening. And this patient um, just continued to spiral downward through that year or two before she came in and understood, and her family understood what post-exertional malaise was. It's really important to educate. We want to educate and educate and educate, not just the parents, the child. You want to educate the teachers. You want to educate anybody that's involved with the child and has any sort of control over their environment or their activities, right? Because kids aren't autonomous. Um, as they get older, they're a little more autonomous, but when you're 12, you go where your parents tell you to go. So we really need to educate them because it's really challenging. Think about it. Parents are trying to make decisions based on how their kid feels in their body, and they don't know. They've never experienced this. If you say, hey, the patient has a burn, it hurts, you can go, oh, I get that, I've had a burn before, it hurts. But they don't understand what post-exertional malaise is, so you really have to spend a lot of time trying to educate. And sometimes there's disbelief. So again, I send them to many different resources. I send them to the CDC website. There's some information about pediatric him on their website. We put in accommodations and modifications both for school and for home. If you have an occupational therapist or a physical therapist who is well versed in ME/CFS or long COVID, they can be a great resource, because I know it's hard to spend a lot of time talking about all of these things. Activity pacing. I think it's interesting. Younger kids, they'll stop. If they're tired, they'll stop. They don't feel that pressure to keep going. They're happy to stop if just whoever's in charge will let them. Older kids are a little different. They have societal pressures. They have, I don't want to miss out on prom, homecoming, and all the things that they shouldn't be missing out on. So those patients, sometimes you have to do more education and more kind of let me help you put the brakes on if you can. Sometimes you can't, sometimes you just have to, explain to them what's going on and they have to make their own decisions. But the more to do for her. So I'm going to do this quick. My time is probably close to end, but let me be clear that this was not 1, 2, 3. Then orthostatic intolerance first, then I hit MCAS 1, 2, 3. It wasn't like that. First thing we did was worked on PIMS. First thing we did is she came out of school. We tried accommodations, modifications. I knew it wasn't going to work, but I wanted to try it. It just, no, it wasn't going to help. She needed more rest. So we pulled her out and we're going to homeschool her. But quite frankly, she didn't do any homeschool for 6 months because she just needed to rest. So we didn't wait the full 6 months before we did anything, but you gave her a month or two to just rest and try to recover. And so then I wanted to start with orthostatic intolerance. And she just was unable. First thing is conservative measures, right? Increased salt and fluids. She couldn't do it. She was nauseated with just minimal amounts. When we tried to add in, it just made her really ill. And this 13-year-old girl said, I had mentioned IV fluids, and she said, that's what I want to do. I can't take it in. I want to do the IV fluids. So when a kid tells you they want IV fluids, they don't feel well. So we did IV fluids. I again start going slow no matter what you do. I started with just half a liter. She was cider, she could get a liter, but we started with half a liter. And eventually what we did it for about a month. We put an IV in, and then depending on how long the IV looked good, we do a bag. 3 days, get a liter for 3 days during that week. On about week 2, we added fludrocortisone. Fludrocortisone works best if you have fluids on board. So whether you're giving them fluids orally, what have you, let them get that going for a couple of weeks before you start the fludrocortisone. So we did that. She didn't have any side effects. She felt okay. She said it didn't really make her feel a whole lot better, but at this point, actually, she was able to start drinking some and taking in some of those oral electrolytes. And so I think she was a little bit better. It's just that it wasn't a huge change for her to realize that it was doing so much. So anyway, at that point, we added in low dose propranolol. Again, my very tiny dose of 5 milligrams once a day for a few days, and we kind of ramped it up. Eventually, she was on 10 TID, and that really helped her. That helped a lot. The flushing went down. She had less of that light and sound sensitivity, didn't have the nightmares anymore. So that seemed to really help. Eventually, we added in midodrine. We also tried, gave her a lot of GI problems, so she couldn't tolerate that. So with this has helped. Again, it hasn't cured her orthotitis, but it helped to make her feel better. It didn't change fatigue. It helped her feel better when she was able to do a few things. Now, kind of interspersed in there, I also started mast cell activation treatment. She'd had loratadine and cetirizine in the past, just, for simple things over the counter mom had given her, and she tolerated them okay. So we started first with loratadine, then we swapped over to cetirizine, and that gave her a little more improvement. This really helped her rashes. She had a lot less sensitivity and just had less issues with rashes. She still had them, but whereas before it would just turn into an all body rash, itching, just it was really miserable. It was just little spots here and there. She'd get them here, around her neck, but it was a lot better. We added in famotidine. I like that one just because famotidine has drug interactions, and sometimes I bump into those. So I just, if I can, I start with famotidine. Sometimes you have to try different ones. It may not be as effective. We eventually put her on montelukast. Again, this was not something I took lightly. She couldn't tolerate cromolyn. It gave her abdominal cramping. Then it made her feel, it also caused nausea. And so we ended up doing montelukast, and this gave some additional control of her GI symptoms. And again, those rashes seem to improve with that as well. And so she's still a work in progress. We're still working. There's a lot of other comorbidities that we just don't have time to go into. But my point about her is that, you know, it's daunting. When you walk into a room and a person is this sick and we don't have, here's the guidelines, step 1 through Z, or A through Z, this is what you do. It's very daunting, and it's intimidating to think I'm going to have to, I have to go in and say, this is what I'm going to trial with your child. There's scientific basis for what I'm doing, but there's not necessarily set guidelines. But here's the thing, if you don't help, who is? These kids need help. These kids need advocates. Even if all you do is hold their hand through their illness and advocate for them and help them with PIM and help them with accommodations and modifications and just simply believe them, you're going to make a difference in their life. Be that person, and when they leave the exam, or when they leave your visit, that they don't cry the whole way home, or they don't feel hopeless the whole way home. Help to encourage them. So, again, I appreciate everybody that's seeing patients with long COVID, especially pediatric patients, and I understand the challenges. So a couple just little quick tips that I learned the hard way. You have to stabilize PIM before really getting into treatment, or at least it doesn't have to be completely gone, but you really need to work on that. If they're in a bad episode, it's a terrible time to start something new. You want to educate about it early. I have patients that have had this illness for years and years and years, and I had a patient not too long ago, an older patient, and she said, my MCAS is flared, my sleep is terrible, my headaches are worse, and every time I stand up, I'm dizzy. And I said, okay, I was, trying to think, and I said, hey, do you think maybe you're in PIM? And she sat and thought, and I said, hey, didn't you say you had this? Yes. Oh, well, that's what it was. It was PIM. But, sometimes we just don't see things like that. And so, just help your patients understand PIM. Again, start low, go slow, one medication at a time. Treat what's treatable, sleep, pain, orthostatic intolerance. The things that you're familiar with are still can be treated in the same way. Stay alert for new diagnoses. Things can still happen that aren't ME/CFS or aren't long COVID, so be alert for that. Make sure you've uncovered. I try to uncover every stone. I don't do labs that I don't want to go get every esoteric lab that exists, but I really do try to look at all the possibilities that could be causing this in case it's something that we can make a difference with. And then we do have guidelines for. So that's what I have. If you guys have any questions.
Thank you, Dr. Hoppers. That was excellent.
Thank
It's
you.
always interesting hearing patients describe how the different mast cell triggers, for example, I had a patient this morning say that she ate bread this morning and that triggered brain fog and shakiness. Other people like vibration can trigger itchiness. And so it's really helpful to hear you explain how to manage it in pediatric populations. And then I was going to just say one more thing, which is that often some patients find that gastrocrom or nasal crom on the skin prior to adhesive application has been helpful. We had a
Yep.
question in the chat real quick, and then we have someone, Allison, with her hand up. Real quick in the chat, other than checking for iron deficiency, is there any medications you use specifically for fatigue, like ADHD meds?
Sometimes I do. Fatigue is hard. Fatigue is really hard. You know, in there's oxaloacetate, but again, there haven't been trials in kids. There's LDN, again, no trials in kids. I'll tell you, I have a patient who is bedbound, 15 years old, been bedbound for 2 years. We tried every single thing we could think of. We paced, we treated OI, we tried this, we tried that, things that were a little more traditional. And finally, I said, okay, it can't be good for you to be in this inflamed state and to be so sick. There's some clinical trials where kids have been given LDN. Essentially, it's safe. There weren't any major, there weren't drug interactions. There weren't any um, complications other than things like nausea, maybe anxieties and things like that. So I started him on LDN and he's had some improvement. He's been able, for the first time in 2 years, he left his house and went for a drive with his mom. So that's what that medication did for him. So LDN can be helpful again. And it's not the first thing I give someone out of the gate. Um, I'm not a maverick, but I also see kids that are suffering. And so I'm not going to completely, you know, not try anything. Um, Also, again, for fatigue, if you can stay out of post-exertional malaise, your baseline should improve. Um, Not only does being in PIM can worsen your baseline, becoming not being in PIM can improve your baseline. So that can be really helpful. I have one kid that's 17 that I did trial oxaloacetate, and that's been helpful for him. So again, something that not the first thing I'm going to use if it hasn't been used or trialed in kids, but those are some of the things we can do for fatigue.
All right, we have two more questions. If you can, um, Allison has a question.
Fantastic presentation,
Thank
Melanie.
you.
Really appreciate it. I'm Allison Escalante. I'm a pediatrician and just consume everything MCAS and long COVID related. Um, One thought, if you don't mind, just a perspective and then a question. Regarding Montelukast singular, I noticed a lot of hesitancy. I was wondering if that's because you're med peds and haven't used it as often in kids, because I have a long history of using singular in kids. And
Mhm.
I would just say that while there are the occasional kids that have mood changes on it, the majority do great with it. And it's really that question where it's the problem with Singular is that it works in about half the kids, and for them it can be
Mhm.
life-changing when we use it for asthma or things like that. And then or chronic urticaria, things like that.
Mhm.
And then for half of kids, it doesn't seem to do anything. But I have seen cases with the mood changes and depression. So I'm not,
Mhm.
I always talk about that carefully. It's just, I maybe don't
Right.
hesitate as much to use it, is what I'm saying.
And I am super conservative. So
Hmm.
it's so treating an illness like this is really hard for me.
Yeah,
Just cards on the table, right? And I also part of my problem is that I'm telling them, if you have asthma, we have literature that says this is okay to use. If you have,
right.
allergies, okay. But with ME/CFS and mast cell, which, there's a lot of there's division on that diagnosis. And I try to be real careful and measured with it because it's not indicated for that. And I know we use things off label, but that's why. And so, but again, you're absolutely right. If that's something, if that, if we've tried other things and I'm going to use it. But it's good to hear you say that. And I'm really excited that you're seeing patients with these illnesses as well. And yeah.
So the specific question I had was about beta blockers. So you used propranolol, as we do. Occasionally metoprolol can be preferred for the kids with asthma because beta blockers can make the asthma worse. But my concern with the beta blockers is on the one hand, they're helpful for the orthostatic intolerance, but then they're known to increase anaphylactic type reactions, and they can worsen the mast cell aspect. And so I guess my question is how you handle that, because I feel like at this point I've come down to art and kind of like playing with what works
Right.
for the individual, but I was wondering if you had a different view on that.
I mean, that is pretty much it, right? First of all, if they have asthma, I avoid them if I can. As a matter of fact, I didn't include this, but the case number one, when she had, I didn't go through all this part, but when she had the reaction, she developed some wheezing. We ended up taking her off the beta blocker and switching her to Avabradine. And it was kind of it was an easy, for her, that was good. It was fine. It helped just as well. It was an even trade. So that was good. Um, so I'm careful with anybody, even if they've had like just a history of reactive airways disease, with colds and things, I'm really careful with that. But it just seems like the propranolol makes them feel so much better.
Right.
Or metoprolol. I use that a
Right.
lot as well. And monitor again, one thing at a time. So if I do one thing at a time and they go, yeah, this is better. I don't have the pounding heart rate and I'm not as light sensitive. But oh, by the way, my mast cell has gone crazy. Then of course, would rethink and try a different approach. It's and sometimes what I do with it is I'll kind of use it PRN as well, right? Like some patients, I'll say you can take it 3 times a day, but they may only take it once in the morning and they find that they're okay. Maybe midday take it, and sometimes they don't take it in the evening. But it's really variable, and it's really I spend a lot of time and follow up. What did this do? How did this affect you? How can we change things? And you're right, it's an art for sure.
Well, you know what? I have more questions, so I'm going to stop and let other people. I'll reach out to you through on Masterminds because there's a group of us PEDS people
Oh
who are
yeah.
discussing these things. So we'd love to
Oh,
loop you
great.
in.
Great.
Okay.
Okay, thank you.
Melanie, can you quickly take one more?
Yes.
David, can you unmute
Yes,
yourself?
yes, thank you, thank you. I have a question and some clarification for case number one, and it probably applies to
Okay.
others as well. So if I remember the case correctly, the patient came in with after having COVID-19, came in with symptoms, chronic fatigue, and all the constellation of symptoms, and you just happened to do the mast cell laboratory workup and then diagnose with an MCAS. My question is, do both diagnoses still valid, or this is long COVID would be a diagnosis of exclusion in this situation, um, or does the person have both?
Well, I think she has both. And I diagnosed her with mast cell activation unspecified. I didn't say she had have labs that were positive. In my area at that time in rural Tennessee, I never got a positive lab. And one thing I found out was, oh wait, the guy that picks up the labs, he goes to all the different clinics and we're a big rural area, so he's driving. He gets one little bag of ice, and by the time he gets, to his third location, the ice is melted. So you couldn't even probably get a positive test in my area. And so I didn't diagnose mast cell activation syndrome, but I do think she had activated mast cells. I think they were twitchy. I think they were part of her problem. I also felt like she had long COVID. She, if I recall correctly, did not have a test because we didn't have testing. Again, we're in rural Tennessee. We don't have a lot of things. Um, but there were family members who had been sick as well. They had lost taste and smell. It was, the middle of the pandemic. And we had a huge numbers of patients coming in with it. So I felt like she did have long COVID. You don't have to have a positive test for the diagnosis of long COVID, according to the National Academy of Medicine criteria. So I based it on that. I can't prove that that her symptoms are from COVID, but I felt like that they were.
So
Does
anybody
that
who
make
comes
sense? Does
in,
that answer your
yeah,
question?
it does, it does. So anybody that comes in with an ME/CFS symptom, with a constellation of symptoms, if you give those the H1 blocker and go through the steps, H2 blocker and leukotrienes and all that, and responds well, the diagnosis is MCAS. Or
Well, it gives
do
you,
these treat all three of them?
well, I feel like that what you're doing is you're helping the activated mast cells when you're treating, say, with H1 blockers, H2 blockers, mast cell stabilizers. Um, I I think that that's part of the pathophysiology of the illness of ME/CFS. I think there's an activated immune state, activated mast cells that are perpetuating. I can't, I don't know for sure, what's going on, but that's part of the process of the illness. And so it doesn't, it may be, it may lend evidence that I'm on the right track when I do it, but I don't, and it's one of the criteria, but the three criteria, the two organ systems, the response to medications, and an elevated validated marker is the criteria that I use for activate for M cell mast cell activation syndrome. This, for me, is a lot of it. I do think semantics are important. I think it's important to be precise. And I think if you can get a diagnosis in that manner, I think that's really great. But I also think sometimes it's very difficult, and you may spend a lot of time trying to do it, and you know, you may be unsuccessful. So I don't want to, dismiss that as a possibility for treatment.
All right. Thank you, everyone. Dr. Hoppers and all the participants. Don't forget to claim CME credit for attending. And our next session will be on January 6th, and we'll discuss pharmacologic treatment approaches for orthostatic intolerance and dysautonomia. And we'll have more time for discussion in our future presentation. So we look forward to seeing you in the new year. Have a great rest of your day.